Good morning. Today joining me is Dr. Mark Meisner. Iliac vein stenting is something that's gained a lot of popularity. Credit needs to go to doctors Raju and Neglin, who really got this going as a minimally invasive option for obstruction of the iliac vein. There's two types: non-thrombotic iliac vein lesions. Maybe you'll hear that called May-Thurner syndrome, or now in nivels, and of course, post-thrombotic, people that have had deep vein thrombosis and then develop a lesion. And they're both a little controversial, but more so on the non-thrombotic side, or we call the nivels. So I'm going to kind of give my anecdote of my experience with this, and then we'll have Mark kind of chime in and we'll go back and forth. These are the kind of what I hope to accomplish today. How did we get here? What does 1A evidence look like? And where do we go from here? All right. So the reason I put this up is because I was in Ed Mackey and I were in Flowood, Mississippi, in Dr. Raju and Neglin's operating room when we got the news that Michael Jackson died. So this is 15 years ago, when we really were watching the pioneers do these things, learning how they select the patients, how they do the procedure, how they interpret an IVUS study and a venogram, how they deploy the stents. And it was, 15 years ago, it was pretty much new at that time. And of course, I took this with great enthusiasm, being a vein guy, adding something else to the practice. I've pretty much just been doing superficial vein work for the 10 years prior to that. So of my vein experience being 100% venous guy, it's been 25 years now. In the last 15, we got into deep veins, and I've learned a little bit. Um, so, Mark, I think you'll agree that, and this has been uh, promulgated by Raju and Neglin, and just to, Raju's a great friend of mine now. Respect the hell out of him, and he's taught me a lot about this. And this all did make sense at the beginning. This Poiseuille's theory and the fourth power of the radius. So the concept being uh, flow in a vein, the predominant variable is the radius, the fourth power of the radius. So we've all seen this slide. So a 16 millimeter common iliac vein. This is the main actor in this story. The common iliac vein, 16 millimeters is normal, or by IVUS, 200 square millimeters. So it would take 16 8 millimeter collateral veins to replicate the flow or conductance of this 16 millimeter vein. It would take 256 4 millimeter collaterals to replicate this. So the point being, we want the big pipe. And then the question becomes, okay, now you've got a patient in front of you, you got a narrowing here. When do you pull the trigger? So as surgeons, we just want a number. Especially when we're trying to teach this, we just want a number. Is it a 50% stenosis? Is it 60? Is it 20? Give us a damn number. We don't need to sort through all the math every day, right? And then we actually took Raju down to the Dominican Republic. We did a lot of work down there for many years. And this is Lowell Kabnick, Raju, and myself. And here I am. Raj, give me a damn number. When do we put a stent in? And, we're kind of going through the math. And there's some cases where he's done 30% stenosis or tighter lesions, but, we couldn't pin him down. And he really goes clinically on this. All right. Now, when we teach this in conferences and discuss this, we really just keep getting back to this 50% where people feel comfortable that anything less than that, they wouldn't want to stent. And this is where you're going to help me, Mark. And then Raju put a couple of us together. myself. Ghassan Kassab is a biomedical engineer out in San Diego. The guy's a wizard, trained with Fung. He is the guy for biomedical engineering. And of course, Fedor Laurie, very well known in our field. And we kind of did this second edition of the hemodynamics for surgeons, of which Mark, your mentor, Eugene Stenosis, was one of the original authors. And here's kind of where I want to get to. When Ghassan wrote about this in the chapter, and he gets into all the equations and derives of how he got here, and I'm not going to pretend I understand Poiseuille's equation, but the bottom line for me is Poiseuille's equation really is designed for rigid tubes. And of course, we're talking about collapsible tubes in the human body. Boundary conditions, meaning if we're talking about this iliac vein in the pelvis, of course, it's in the pretty much lower abdominal cavity. There's organs on top of it. The vein empties into the right atrium. The vein is fed by the legs, rich networks. This is a complex system. So how can this one lesion in the pelvis, when you've got this entire venous system, the human body, be the main culprit of the story? And in my mind now, I don't have a number. I would just say that, and I'm gonna kind of get out of this. Or there's one more slide I want to show. Okay, we've all seen patients that do well, nibbles that do well with an iliac vein stent, life-changing, and then you got others that, made no difference, and you have this stent in them now, and you don't feel very good about it. So is it a predictable lesion? Do we have a good number where a stent's going to work? And again, let's just focus on non-thrombotic. We can talk a little bit about post-thrombotic, but I think the non-thrombotic story has gotten very confusing, especially when Poiseuille's equation maybe doesn't hold up in the human body. And then I just love this landmark study by Melina Kibbe 20 years ago, where just folks came to the ER and they got CAT scans for other reasons, and they went back and looked at the iliac vein, no leg symptoms, and basically came out with 25% of us have greater than 50% stenosis in our iliac veins and no symptoms. So how do you put such a heavy emphasis on this stenosis in the common iliac vein for leg symptoms? Mark, do you agree with me, disagree with me? Where have you kind of landed on this, and how do you think about this? Because you've been to all the meetings that I have.
Well, Jose, I completely agree with you. And let's go back to Poiseuille's equation. This is kind of a rearranged version of the same equation you showed, Jose. And I think it's important to kind of recognize that a lot of what we do comes from the arterial system, and particularly this concept of a critical stenosis is very different in the arterial system and the venous system. You have to remember, in arteries, what we're really interested in as far as causing symptoms is a reduction in downstream flow, that is distal to a lesion. And what we're really interested in veins is not so much flow, but an increase in upstream pressure. And in particular, I would say that's a symptomatic increase in upstream pressure. And that's really what we're aiming for, is to not have a symptomatic increase in upstream pressure, that is caudal pressure towards the feet. And if you rearrange Poiseuille's equation, you get this pressure drop is equivalent to viscosity, or mu, 128 times viscosity flow, and then pi times the fourth power of the diameter, which is very similar to what you showed. So I think this equation is important in kind of understanding the determinants of increases in upstream pressure. Depends on viscosity, on flow, and on the diameter of the pipe. Very similar to what you said. And people have used this. Raju, this is a paper by Raju just to demonstrate how this has been used, looking at the optimal diameter of venous stents. And just looking at the pressure gradient at rest with exercise with a 50% in-stent stenosis for various stents. And you can see there's a pretty dramatic increase, particularly with exercise, is somewhere between 18 and 14 millimeters. And, based on this, Raju sort of determined, based on Purcell's equation, that the optimal stent diameter for the common iliac vein is 18 millimeters. And you can see as you get less than that, pressures, particularly with exercise, go up relatively dramatically. As you mentioned, the problem is that this is really applicable to rigid tubes and idealized flow. And veins are compliant. They're not rigid tubes. They're elliptical. They're not circular. Blood, particularly in smaller veins, is a non-Newtonian fluid, and the flow rate's not steady. So I think this equation is important to understand the determinants. And if you're looking for a number, this is really great for plumbers and civil engineers. When you can calculate flow in the outflow of a dam or in a pipe or something, it works great. But, well, I'm not a civil engineer. I presume it works great, and they use this to calculate these things. But if you're looking for a number as a physician or as a patient, you can't use this equation to come up with an absolute number. It's great for understanding the principles involved, but not so great at coming up with a number. And I think kind of the takeaway message from this, and a lot of this is based on Raju's work as well, Jose, is that probably in veins, there is no critical stenosis. As you mentioned, there's too many determinants of this increase in upstream pressure. Right-sided heart pressure, central venous hypertension contribute to it. Obesity contributes to it. The degree of stenosis contributes to it. And all of this is different in every single patient. That you really can't come up with a critical stenosis for it.
Mark, let me just kind of recap what you said. So with the arterial system, which is perfusion of an end organ, versus the venous system, which is drainage of an end organ, it's pretty well accepted that there's in the arterial system, there's a steep pressure reduction or perfusion reduction at about 75% stenosis. We've got a number for it. The artery basically behind it is the heart. And I don't know that there's, versus drainage, we've got this sponge of little venules and capillaries draining into these veins that get a little bigger, and then they get a little bigger, and then they centralize to this common iliac vein. And collateralization seems to be more of a story on the venous side, so which complicates it matter further. The collateral formation capacity in the calf seems to be great versus limited collateral formation capacity in the pelvis, which has been one of the stories why this pelvic lesion is so important. But it's for me the story and now this turns into a belief. So maybe, Mark, we can talk about what 1A evidence really means, and then what surgical experience means when you got patients in front of you. So 1A evidence to me means that no matter what data comes out in the future, it is highly unlikely to change the treatment recommendation for whatever that issue is, for whatever that 1A data story is, saphenous vein ablation, let's say. It's very unlikely that in the future, some evidence comes out that now the saphenous reflux is, the story will be leave the saphenous vein alone. Versus this iliac story now, we don't have great randomized controlled trials. Clearly, it's not 1A. And when it's not 1A, then it's more incumbent upon the operator to know the literature to say, these are the strengths, these are the weaknesses of what we know, and how do we apply it in this situation? Is that kind of what the evidence story, the graded evidence means to you?
More or less, Jose. I kind of break it up a little bit more in looking at what the ones twos versus the A's and B's actually mean. The A, B, and C is the level of evidence, and you're exactly right. Level C evidence is likely to change as further data comes available. Level A evidence is very secure and not likely to change. So I think on the strength of the evidence side, we can change things from C to B or A, but separate that from the ones and twos. And ones are such strong recommendations that the benefits of the procedure will always exceed the risks. In grade two, it's more balanced. And I always like to say, you've heard me say that before, grade one recommendations are Nike recommendations. They're just do it recommendations. Grade two recommendations is always 100% of the time going to depend somewhat on patient preference. And I think if you look for most of what we do in venous disease, it will never be a grade one recommendation because this is a quality of life disease, and patients are going to choose different things based on how it's presented to them and the discussion with them. And while a patient with, say, an obese patient or somebody with multiple causes of swelling, as most patients have, and they have 70% iliac compression, and you present the patient, well, I don't think your swelling is just due to this lesion. It may be a contributor to it, but probably your obesity is a big problem. Your amlodipine is a problem. All of that needs to be maximized. I think, if we stent that high-grade compression, you may be a little bit better, but it's not going to resolve the problem. Different patients may choose different things. So I personally think that, although we can increase the evidence base and increase the ABC part of it, we're never going to change the one versus two just because it's going to depend on the patient with it, is the way I look at it.
Would you put this at a 2C right now, Nibbles, the breadth of the evidence?
I would, because, really the level of the evidence is based on randomized trials start high and decrease depending on how strong they are. Anecdotal and case series start low and increase. So certainly, and that's all based on looking at the width of the confidence intervals, if you can even do a meta-analysis of it. So I would say it certainly fits in a 2C right now. And the 2, I don't think we're going to change. The C will be harder. And I guess the question really becomes, could you even ever do a randomized trial for the treatment of non-thrombotic lesions? When you look at the literature about the breadth of the patient population that is reported in the literature and based in various case series, there are as low, there's some percentage of patients who are being stented for C1 disease in the literature. There's certainly a moderate number of patients who are being stented for C2 disease. If you look overall, and I've looked at it, about 40% of the patients in the literature are being stented for C3 disease. And I think we all know that C3 disease is a very, very tricky area, and that most often, edema is multifactorial. There's more than one factor contributing to leg symptoms. And then C5 and 6 is probably the other 40% of them. And so if you're going to do a randomized trial, are you just going to confine it to patients with C5 and 6 disease, which would probably be the only kind of trial you could do? C3, I think, is just too variable to include those patients in. It's going to be hard to get a signal because there's so much noise involved in it. Right. And I don't think most of us really believe that C2 and C1 patients ought to be treated with stenting. So you're going to do a wound care trial, and ultimately you're going to have to look at wound healing. You're going to need a large number of patients to do that. And although theoretically possible to do this in C5 and 6 patients, I think it'd be very difficult.
Yeah, at least with C5 and 6, you don't feel that you're doing harm, especially C6. C6 is so difficult that you really, throw the kitchen sink at those people.
Right.
And even with everything wide open, as we all know, they can recur. But yeah, so just let's maybe get this into some practical points that can help our colleagues. So just So when I see a nibble now, or a leg, if it's bilateral symmetric swelling, I pretty much tell the patient we think more of a system issue, medication, obesity, salt intake, lack of movement. But when it's unilateral and asymmetric, then we think more of the plumbing. This is my, words to patients. And then, so they'll come back for a iliac vein, a lower extremity duplex ultrasound, including the iliac veins, fasting. And my tech, who's been with me about 20 years, really, Jan Sloves, who's an excellent tech up in New York and really, focused on this, was down here a lot. And we got pretty confident that when I have a duplex ultrasound and we don't go to cross-sectional imaging, we go straight to IVUS with the plan of an intervention. I don't know what our actual, but I'd say 95% of the time, what she showed me on duplex is what I see on IVUS. So I've got a lot of confidence going from duplex to IVUS. Now, what do I look for on duplex? Well, again, if it's swelling only, um, even with tight lesions that got stented, some have, very happy, and others, I always tell them you'll get a little better. Now I'm not even so sure I do it for swelling only. I go to this something called the misery index. How miserable is this leg making you? Is it an 8, a 9 on a scale of 10? That you gotta kind of ask me to stent you. I'm not going to convince you that you need a stent. You need to be asking for this thing. That tells me you're miserable, and that the risk and the benefits may align. If you're not miserable and can get away with a stocking, I'd rather just monitor you once a year. So let's put that aside for a second. Then they go on the internet and ask Dr. Google, and now, well, these things cause DVTs. And so that part of the story is, the hospital folks, when they see massive DVTs and they declot the leg, they will often uncover one of these lesions. So is it cause, effect, or correlation? But now we start thinking, yeah, maybe these things can cause DVT. But after following all these legs for 15 years conservatively, and I mean tight lesions, closed lesions, they don't seem to cause DVT to me. And the only Chinese study that I'm aware of that looked at this, the bottom line was they don't cause DVT. But if you have a deep vein thrombosis with an iliac vein lesion, it's more likely to extend into an iliofemoral DVT. So the severity of it will increase, but there's no cause effect of an iliac vein lesion with deep vein thrombosis and I kind of, again, believe that based on my experience. So on the duplex, and again, my tech's gotten good at not pushing down too much so that there's compression from her probe pressure. She'll do some, ask the patient to get LAO, RAO, and see if the vein will open up a little bit. And if it's 4 millimeters or larger, 4 or 5 millimeter, 8 millimeter common iliac vein, 8 millimeter, of course, be 50%. 6 millimeter, 4 millimeters when I start to, my eyebrow goes up a little bit, or I'd consider it. But not until really I see 2 or 3 millimeters. This thing's smashed on duplex and severity of symptoms, will I really offer them, to do this thing? And then we do them with local anesthesia in the office and nibbles, post thrombotics in the hospital. And by and large, that's working out okay for me, but still, I'll get some folks that if I did it for swelling only, they told me, and the swelling won't resolve. And then you got to wonder, well, how much underlying lymphatic disease is there? Well, the foot and toes weren't involved. It was just the ankle. Does that mean they don't have lymphedema? No, I guess lymphedema is a spectrum like everything else, and a lot of this could be lymphedema. So tell me where you're at now. Patients in front of you, how do you deal with these?
But Jose, I kind of agree with you on the C5 and 6 disease. I will usually always treat their superficial for nibbles, always treat any superficial disease first and see how their wound healing progresses and if they have a recurrence. If they're not progressing in their wound healing or they have a recurrence, then put the stent in. That seems pretty easy because the downside is pretty low with that. I agree with you on the C3 disease. And my starting point is always to never start with the nibble. And I just have kind of a checklist I go down on the causes of leg swelling. Always start with medications. I don't know how many patients I get sent by primary care physicians. You start with their medications and you go, oh, it's your calcium channel blocker. Ask your primary care physician if you can come off of this. And that's just really common. So always start with medications. It's an uncommon cause overall, but the most common medication that's responsible for edema is probably ibuprofen in people who take massive doses of it. Probably not a patient who takes it intermittently for a little musculoskeletal pain. But I always start with medications, and then I look for causes of central venous hypertension. Do they have any signs of any heart disease that would lead to elevated right-sided pressures? And if I have any suspicion, I'll usually get an echo before I get a duplex scan, just to make sure their right-sided pressures aren't high if I have a reason to suspect that. Then I look at obesity. And, a lot of these patients do have some obesity first. And then kind of as a fourth thing, well, do you have an iliac stenosis? And I always talk to the patient before even ordering the ultrasound. I say, do you really want to go down this pathway? You got these other causes of edema, and it can even be unilateral edema because some of these factors, the iliac lesion may be permissive for these other factors that are really, causing their legs to swell, and it can be asymmetric. And that edema will get better if they lose some weight or correct their central venous hypertension. So I always talk to them first. You really want to go down the pathway that may end up with you getting a stent that is not going to make you better. And if even you look at the large series of Raju, you look at all of the patients he stented, only about 30% of patients with C3 disease will have complete resolution of their swelling. And that's kind of consistent across the series. 70% of the patients are not going to have complete resolution. Some of those patients will have a subjective improvement in their swelling, but swelling is just a complicated disease. I agree with you on, I don't get cross-sectional imaging on any of these patients. We start with ultrasound, and we do kind of exactly what you do, and maybe I'll share my screen again and just show you some images from
Mark, while you're doing that, I'd like to emphasize, because you look at the Raju Negrin data, and I think they've done a great job, and yeah, you see 70%. So they really typically will report pain, ulcer healing, and relief of edema. Those three, and they're never 100%. And it's right there in front of you. Yet you kind of look at the good number. Well, 70% of the swelling will go away. So this is initially being the enthusiast. Well, almost all swelling goes away. Let me just stent it. And that's clearly not where I am now. But the data's always been there. I think they've been honest about it.
Yeah,
but it still gets to this damn number of percent stenosis where Raju will stent some 20% stenosis lesions if he thinks the symptoms are from it. And I just would never do that. So, we're still got this central problem of the discussion we're having of assigning a number to this lesion, if that's even doable or does it make any sense to assign a number to a venous lesion? But anyways.
I just showed these ones to demonstrate what you said, Jose. These are from Erwin Tunder, who's a very good vascular technologist in the Netherlands, has some very nice pictures just showing the difference in iliac compression between the supine and the upright position. And then slide from Kathy Gibson, just showing the respiratory variability in this. And I think the takeaway message is you can make anything look like a 70% stenosis if in various conditions. And that's why we always, if we see something, we'll do just like you do, either stand the patient up or have them roll on their side and make sure it goes away. And the problem is IVUS is also done supine. I'm not to the point yet where I do what Kathy Gibson does of rolling the patient on their side with the IVUS catheter in to look at it, but I think that makes a lot of sense with it. So I completely agree on the standpoint of not necessarily needing cross-sectional imaging for these.
And IVUS now we've gotten to the problem of, okay, is it area, is it diameter, or is it perimeter? Because you get different numbers there, and now there's now we're on that story and all the disagreement there on what you're actually measuring. So it's gotten very difficult to decide what to do with these nibbles.
Yeah, and I getting back, to what you commented on, is there really anything we can hang our hat on, our number? And I think you and I both agree that there really is nothing to hang your hat on, and I think it's really well supported in the literature that the 50% threshold is nonsense. And I will share two more slides here.
Yeah.
People have seen these all before. This is the video trial. So remember the video trial?
Yep. Paul Gagne and
Yeah, and none of these were C3. These were all C4 to C6 patients. 68 of these were stented based on IVUS with a mean area stenosis of 59%. I think, and about 70% of them were non-thrombotic. Only 30% were post-thrombotic. And I think this is one of the benefits of this trial is they actually had an objective measure of clinical improvement, unlike partial improvement in swelling, partial improvement in pain. They defined clinical improvement very objectively as a greater than 4-point improvement in the BCSS score. And most of these patients didn't get better. Only 41% of these 68 patients actually got better. And, the overall performance, 54% area reduction by IVUS was the optimal threshold. And you look at this, the sensitivity is very good, meaning the patients who did improve all had a greater than 54% area reduction, but the specificity was horrible. Most of the patients who were stented for this did not improve. So the diagnostic accuracy was very poor. And the same goes for the non-thrombotic optimal performance of 61%. The patients who do improve had this, but most of the patients who had this didn't improve. And this isn't in the paper, but just doing the calculations on it, the positive predictive value of this 50% stenosis is less than 50%, and if you're going to put a number down, I would say do the IVUS and then just flip a coin. You'll be more accurate. At least you'll be right 50% of the time rather than 45% of the time. And I think this doesn't really have any diagnostic utility in this population. And it's probably not going to be any better in C3 disease. And if you look at Raju's data on it, this is from Arjun Jayaraj, who I think everybody knows. And Arjun looked at 480 limbs. This is kind of the opposite of the previous one. Most of these were post-thrombotic. And in contrast to what a lot of people do, including myself, he defines stenosis, kind of based on these numbers that are derived from both clinical and a number of theoretic concerns. But for the common iliac vein, defined it in comparison to this reference norm of 200 square millimeters. And looking at improvement in DCSS versus percent stenosis, this is almost flat. There is a very weak correlation. The R value is 0.12. But if you just look at the graph, there's almost no correlation between improvement and the degree of stenosis. And if you look at BCSS scores, it's pretty identical whether those patients had less than 50% or greater than 50%. But again, you look at the absolute numbers, this threshold is much lower than used in the video trial. We're talking about a 2-point improvement in BCSS versus the 4-point that was required in the video trial. And improvement in quality of life on the Civic 20 also didn't, it wasn't any different whether you were less than 50% or greater than 50%. So I think the takeaway from that is there probably isn't a number.
I mean, that almost argues, both ways where, okay, a 30% lesion could be causing the symptoms and a stent would help them, which is, I think, what some of our colleagues may believe out there. Um, so maybe as we wind this down, let me just try and nail you down. Would you ever stent a 30% stenosis nipple?
No.
Legs blown up, patients miserable, put it up
Well,
there, 30%.
I guess I wouldn't say never ever, but it wouldn't be my first intervention. I would go through the checklist just as we described, look for other causes of edema. I certainly would never stent a.
I mean, you've already made a decision. For me, when they're on the table, I've already decided if I see what I'm looking for, they're getting a stent. Now,
Exactly.
I've got this miserable patient. I've decided you're on the table now, and I look up and I measure is it 30 is 30%. Would I ever put a stent in if you ask me? No, I would not. What's the number I look for? It's got to be more than 50%. So I'm back to this stupid number that, I got to have at least 50%. If I've made a decision, they're on the table, clinically, they're miserable. But I see 40, I'm not going to do it. And if I see 55, I probably will. So I use this stupid 50% number. And
Except for Jose, what you're telling me is you really don't use a 50% number. You're looking at the patient's overall clinical condition and correlating it with what you see on the imaging
yeah,
and finding out it. So you're not throwing an IVUS catheter in there and going, oh, there's a 50% stenosis. I'm going to treat it. And I think that's the takeaway message from this isn't a cookbook and never will be a cookbook. And it's part of the joy of medicine is you have to do some decision making based on how the patient's presentation is, what their values and preferences are, and what the studies show. It's not picking a number and just sending everybody who has that number, which is what you're telling me you're doing.
right. So maybe another way to ask the question, would you ever see one disease? Would you even ever consider them for number one, looking up top with an ultrasound, and number two, stenting them? C1 disease.
That's an interesting question because you talk to people who have stented C1 disease, and some of it actually makes sense because remember the one thing that's not included in C is venous claudication. And to be honest with you, I don't see it. Well, it is rare, if ever, that I see a nipple lesion causing venous claudication. I see lots of post-thrombotic lesions causing that. And so if I had a C1 patient who had venous claudication, even though they had venous claudication, they'd be a C1. I would consider it for a post-thrombotic patient with venous claudication. For a nibble, probably never. I just don't see patients with venous claudication and nibbles.
I never have. C2, would you ever stent to C2?
Same deal.
Yeah.
If it's post-thrombotic and they have venous claudication, maybe. For a nibble with just C2 disease, never.
And then, as you said, C3 starts getting a little washy.
Yeah.
C4, you start C4 through 6, you start feeling better about it. At least there's some skin damage there. So I think now the threshold that we want lays on C3-ish, and I still think we're at 50%-ish as far as the lesion, as far as considering laying down some metal. C1, C2, I'd put that as an almost never. Less than 50% stenosis, no matter what they have, I'd almost call that a never for me.
or
Um,
C3 or C1 too.
so C1, C2, they're not even getting an iliac ultrasound. It's not even in the discussion for me. So even the enter discussion is C3. That gets you in the discussion. I do an ultrasound, and then if you make it to the table, then I need at least 50%. And we're talking about nibbles now. PTS is a whole different animal. So that's kind of where I'm at.
So how much, Jose, do you rely on just that number versus the other things we talk about? Collateral patterns, seeing that ascending lumbar going up, seeing at least
Yeah,
a
that's interesting. Yeah, I mean, I like to see that pancake looking venogram. I like to see some ascending collaterals, maybe an ascending lumbar. I feel much better when I see that, and the number's 50%. If the number's 50% and I don't see that, I'm not very happy about putting a stent in. So that's a whole nother animal too, the whole collateral circulation there and the role of that. So, um,
I do like to see at least some evidence of some collateralization, and then I usually I most of the time in those ones that are 50% ish will do a balloon test and put a 16 millimeter balloon in, see if there's a waste, and then inject contrast. And if there's contrast flow around a 16 millimeter stent, they don't need one. And that's one of the things that really bothers me is we've come up with, at least promulgating, that all nibble stents ought to be landed in the external iliac vein to prevent migration. Well, if
yeah,
a 16 millimeter stent migrates, you've made the wrong decision.
yeah,
And I personally generally land stents in the external iliac vein because I do a number of maneuvers to make sure that patient really needs a stent, and if you're going to put a 16 millimeter stent, I'm very secure it's not going to migrate,
not going anywhere.
because I've done the balloon test and everything else. It bothers me that we've come up with an algorithm to make it safe to stent patients who don't need stents.
Yeah, no, that's always a good point that you make, and there are people using this balloon test. So yeah, for the listeners, you in the common iliac vein, put a 16 millimeter balloon now, inflate it, and inject contrast from below. If you see contrast going around the balloon and emptying into the vena cava, that's a sign that that lesion is not very tight, and perhaps a stent may migrate if you don't, put a long stent in, or to your point, maybe they don't need a stent at all. The only issue with that is it only takes 1 to 2 atmospheres of atmospheric pressure with a balloon to open a nibble. So that one's not so absolute either for me. Uh, what is clear, you got this artery on top and the lumbar below, you got two rigid structures, and ballooning a lesion alone without a stent is not going to work. So if you've got the 2 point compression, the crush resistance, the stent property would be crush resistance. So you have these two structures. So nibble's really the 2 point. You need crush resistance. It's not the circumferential chronic outward force or radial force that we need with a post thrombotic, where the entire vein is sclerosed from the post thrombotic process from the thrombus. So this is a 2 point compression. You got a rigid structure above, rigid structure below. And even so, you don't need much atmospheric pressure on a balloon to open it. Of course, you let go of the pressure on the balloon, it goes right back down. So balloon angioplasty alone will not work for these. You have to stent them if that's what you decide. But I still haven't gotten confidence in that balloon test. I just really, I'm there to, I'm confident that when they're on the table, I'm there to stent them, and it's going to take something less than 50% to walk away from it and not stent them. So and I too tend to use the longer stent just because of the paranoia. I mean, God Almighty, if you 6 months later that thing's sitting in the right atrium, that's just, I mean, freaking disaster. So I would just rather put the damn long stent in and sleep at night. So 16 by 120 is my workhorse. Um, Never had one migrate, thankfully. But um, what else as far as parting words? Because I know you got to get to clinic, and we're getting short on time. Um, anything else to add as far as where do we go? Let's do this. Where do we go from here?
Well, I really think education is the main thing, Jose. And I think you shouldn't be doing this if you need a cookbook to do it. That you see A, B, and C, and A, B, C, and I'm going to stent. This is all clinical judgment combined with imaging. We're not just treating images, we're treating patients. And if you're uncomfortable with not having a cookbook that says 50% stenosis, I put in a stent, you probably shouldn't be doing this. So I think it just does require experience and good clinical judgment, and just combining everything you have at hand, the patient's history, their physical, and the imaging, and coming up with a solution for it. And in the end, like I said, I think the Pucell's equation, to go back where we start, is great if you're a civil engineer or a plumber working with rigid pipes. We don't have that luxury, which is why we do this. Is it takes clinical judgment.
So then the last question, is there any study that you anticipate or data coming forward that would give us more, to hang a hat on something, a number or some type of trial that would answer this, or will it never be answerable?
I think it will be answerable in some situations. I look at the probably there's a couple of clinical trials that are ongoing, but I look at like the Embolize trial for pelvic venous origin pelvic pain that Ron Whitaker is doing that entirely excludes any patient with an iliac compression. It's not going to answer that question at all. After the data for that one is, I think it would be good to do a trial in patients with venous origin chronic pelvic pain and stenting, because I think that's a much more uniform patient population. And if you can take a patient that you can demonstrate symptomatic pelvic varices, no ovarian vein reflux at all, and that might answer some questions is coming up with a threshold. But I think that's 5 to 10 years off. It's not going to happen soon. I think you could look at ulcer healing. That'd be, or the patients with C5-6 disease, great population. I know of no trials that are looking at that now, but that's also a fairly uniform patient population to do a trial in. So I think probably after our careers are over, Jose, we'll have some better answers. But for the present, you got to use your.
Fair enough. I think we should leave it right there. Mark, want to thank you for spending the time and your brilliance, and hopefully this will be valuable for our colleagues out there.
Thank you for the invitation, Jose. Always great to just sit around and talk about something.
Yeah, absolutely. And enjoy the rest of your day.
Thank you.
Thanks.